If someone is standing in front of the drinks case, the question is not, are sweeteners pure or poisonous? It is compared with what? Compared with regular soda, water, coffee with sugar, juice, or an afternoon pastry. Is that the first fork in the road?
Exactly. Non-sugar sweeteners are most defensible when they displace free sugar. In a 2025 randomized trial, advice to reduce free sugar lowered free sugar intake by about 2.5 to 3.3% of total energy versus a smaller control change over 12 weeks, and intervention groups had slightly lower weight. That does not prove sweeteners cause the whole effect, but it shows the target: reduce sugar exposure in a practical diet. The physiology starts with a missing calorie load. Table sugar brings carbohydrate energy, raises oral acid production, and can add quickly to daily intake. High-intensity sweeteners taste sweet at tiny amounts, so the drink or yogurt can be much lower in calories. But the body still sees the full food pattern around it: hunger, habits, compensation, and whether dinner gets larger because lunch felt saved.
That is where viewers get stuck. Some people say diet drinks trick the brain and make you hungrier. Others say they help by removing calories. What does the better evidence say about appetite and weight, not just a single snack test?
The most practical answer is modest substitution benefit, not appetite wizardry. If a sweetener replaces sugar and the person does not replace those calories elsewhere, total intake can fall. The recent free sugar trial supports that general direction, while beverage cohort studies cannot cleanly prove causation because people at higher metabolic risk may choose diet drinks after gaining weight or receiving warnings. Compared with water, the story is less exciting. A diet drink may be useful as a bridge away from sugar, especially for someone drinking multiple sugary beverages. But if the choice is already water, unsweetened tea, or coffee without sugar, there is no calorie deficit to create. The sweetener is then more about preference, adherence, and avoiding a return to sugar.
So when a label says aspartame, sucralose, stevia, or another sweetener, should people read that as automatically dangerous? Or is safety approval a different lane from the long-term question of whether a diet pattern built around sweet drinks is ideal?
Right. Safety review asks whether expected exposures stay within acceptable limits. And different sweeteners have different biological fates. Some are metabolized, some are mostly excreted, and sugar alcohols can reach the colon and pull water or feed microbes. That is why lumping every packet into one chemical category is scientifically sloppy. Dose, compound, product form, and the person's gut response all matter.
What about teeth? People often talk about weight and diabetes, but the mouth is the first tissue seeing the sweet drink. Is aspartame actually protective for teeth, or is it simply less harmful than bathing oral bacteria in sucrose?
The 2025 systematic review is useful because it keeps the claim small. Aspartame looked less acidogenic than sucrose and similar to water in limited clinical data, while animal and lab studies generally found fewer caries when aspartame replaced sugar. But the authors caution that this is mostly non-cariogenic substitution. It is not strong evidence that aspartame has a special anti-cavity biological effect. This is also why fruit is not just sugar with vitamins. A kiwi fruit trial showed that whole pulp reduced the glucose response to co-consumed starch, with fiber and organic acids slowing absorption. That does not make fruit unlimited, but it shows a food matrix can change physiology. A sweetened beverage, even low-calorie, does not bring the same fiber, chewing, volume, or micronutrient package.
Who is the best fit user, then? Is it someone with several sugary drinks a day, someone trying to lower free sugar, someone with dental concerns, or someone who already eats mostly whole foods and just likes a diet soda at lunch?
Best fit still has boundaries. Anyone with phenylketonuria must avoid phenylalanine sources, such as aspartame-containing products. Pregnancy usually calls for staying within established food use exposures and asking a clinician when intake is high or the diet is restricted. Sugar alcohols can cause gas, cramping, or diarrhea in sensitive people. And concentrated powders or unusual high-dose use should not be treated like normal foods.
The long-term cohort numbers sound scary, though. If non-sugar sweetened beverages are associated with stroke, coronary disease, hypertension, diabetes, and mortality, why not tell everyone to stop immediately? What keeps that from being a simple causal verdict?
Because the magnitudes are generally small and the design is observational. The 2025 Umbrella Review reported associations such as all-cause mortality hazard ratio 1.06 per 355 milliliters per day, stroke 1.09 per 250 milliliters, and coronary heart disease 1.06 per 250 milliliters. Those deserve respect, especially for heavy daily use, but they cannot fully separate sweetener effect from why people chose those beverages in the first place. So the careful advice is not panic. It is pattern review. If someone has diabetes, kidney disease, pregnancy questions, recurrent digestive symptoms, an eating disorder history, or major medication changes, they should individualize with a clinician or dietitian. Also, if diet drinks are crowding out water, milk alternatives with nutrients, or actual meals, the issue is no longer sweetener toxicology. It is dietary adequacy in behavior. A simple 2-week test works better than ideology. First, define the substitution. I am replacing 2 sugary drinks, not I am adding diet soda. Second, track outcomes that match the goal. Fewer sugar grams, fewer cavities risk sipping episodes, less total energy, stable hunger, and no gut symptoms. Third, after the bridge period, see whether some servings can become water or unsweetened drinks.